Guys, welcome back to my channel. Today's video is going to be part 1 of my diagnosis spotlight series. I thought that maybe I could do just an emphasis on certain diagnoses that maybe we're not too familiar with, or just kind of go over several systems. I kind of want to focus now on cardiac. I'm going to go over the cyanotic heart defects in this video. But look out for future videos with the name Diagnosis Spotlight Series, and you'll see that I'll be, just enhancing or emphasizing certain aspects of each diagnosis. That way, it's not such a long video, because I'm fearful that if I go in depth, like too in depth in each diagnosis, that these videos are going to be very, very long. So I'm just going to focus this one on cyanotic cardiac defects, and if you guys are interested, let's get into the nitty gritty. First, I'm going to go over the cyanotic defects of the heart. There are several. I'm going to do my best to try to cover them quickly, but also somewhat in depth. So the first one I'm going to go over is Tetrology of Fallot, or TOF. It's characterized by 4 defects, hence the name Tetra. The signs and symptoms you'll see in your patient would be cyanosis, hypoxia, dyspnea, tachypnea, a heart murmur, or a boot-shaped heart. So the 4 defects that I'm going to go over. The first one is pulmonary stenosis. What's involved in pulmonary stenosis is that the pulmonary valve is either too small or too narrow, or stiff. So, and this is the valve that connects the right ventricle to the pulmonary artery. Okay. The next defect in Tetralogy of Fallot is what's called a VSD, which is known as ventricular septal defect. So pretty much this is just a hole in the heart. It's pretty common in newborns. It's a hole in the heart between the 2 ventricles. And I mentioned what ventricles are in my other video explaining how blood flows through the heart. Next, in this I don't know what I'm trying to say. Next part of this disease process is an overriding aorta. So what an overriding aorta is pretty much that the aorta, instead of being directly over the left ventricle, it's directly connected above the VSD. So not where it's supposed to be. And then last but not least, oops. It's right ventricular hypertrophy. So pretty much what this is that the walls of the right ventricle are thickened due to chronic pressure overload. And this can be seen in an ECG. The ECG will show an RS ratio.
RS ratio that is greater than 1, or you'll see the R wave taller than 7 millimeters. So greater than 7 millimeters, and it's the thickening of right ventricular walls due to chronic pressure overload. Now, how do you treat this? So, let's go over the treatment now. So this is surgical, definitely surgical. But prior to the surgery, you're gonna treat them with propranolol. You're gonna be careful with your use of oxygen. You don't want to, because they're going to be cyanotic, so it's not like you're going to just give them 100% oxygen to compensate the fact that they're going blue. It's never going to change. There is a defect in the heart. The only way to prevent them from going blue is to repair the defects. Then what you want to do is put them on prostaglandin. E. So prostaglandin E is to keep the ductus arteriosus patent. So you want to keep the PDA open, patent ductus arteriosus. Okay, you want to keep it open because this is going to help them to oxygenate the blood. It's a fetal shunt that goes away with time, but for these babies, you want to keep them open until they're able to repair the defect. Then what you want to do is, when it comes to the surgery, is note that there's a name for a procedure that they would do. It's called the Blalock-Taussig shunt. So this is a corrective procedure that is going to increase blood flow to the lungs to oxygenate the blood better, where they take a branch or branches of the subclavian artery or carotid artery and connect that to the pulmonary artery. So they're creating another shunt. And not like the fetal shunt that I just explained, this is a surgical shunt that they're putting in so that the blood will flow naturally through this shunt to the lungs to oxygenate the heart, the whole body better. Okay, and then with the surgery, that's one surgery right there. Then there's what they'll do is they'll correct the VSD. So they'll put a patch to close the hole. And then they'll remove the thickened tissue in the right ventricle and repair the pulmonary stenosis or the pulmonary valve that's narrow. So they'll repair the valve so that they can get more blood to go through there. So in a sense, they'll enlarge it. Okay? And then that's pretty much it. All right, that's Tetrology of Fallot. All right, remember the 4 defects: pulmonary stenosis, ventricular septal defect, overriding aorta, and right ventricular hypertrophy. So for sure, if you're going to be taking the CCRN for neonatals, this is definitely going to be on there. 100% on there. Okay, either how to fix it, a sign and symptom of it, or what they are. Sometimes it's just straight content and it'll just be literally the 4 defects. Next, I'm going to cover the transposition of the great arteries. This is another cyanotic defect of the heart. It's also known as dextrotransposition of the great arteries. Pretty much in this, the main arteries of the heart are reversed, which is the pulmonary artery and the aorta. It is a cardiac emergency. It is predominantly noted in male patients, and it is usually diagnosed in utero or within the first hours of life. The signs and symptoms, you'd see a baby with cyanosis or respiratory distress. So let's go over transposition of the great arteries. So the pulmonary artery and the aorta are switched. So what ends up happening is the oxygen-rich blood circulates through the left side of the heart to the lungs and back, and never ever circulates through the body. And then the oxygen poor blood, so this blood never goes through to the lungs to get oxygenated, circulates through the right side of the heart to the body without ever getting oxygenated by the lungs. So never circulates through the lungs. So as you can see, this would definitely cause cyanosis. You're going to have super blue skin. Now, to repair this, it seems pretty simple, but also very dangerous. It's a surgical procedure that it's called the arterial switch. So they just pretty much flop the vessels to where they're supposed to go. But before we get to the surgery, it is important to maintain, this is another one, a ductal dependent issue, maintain the ductus arteriosus open. You need to keep the PDA open. And you're going to use prostaglandin E as well. This helps the blood mix a little so that at least some oxygen-rich blood is circulating through the body. This is definitely a cardiac emergency. It's diagnosed in utero, so most of the time if you have a mom that's about to deliver, you're going to have like the cardiac team on hand. If you have a baby being delivered in a hospital that does not have a cardiac team, you're going to have the helicopter ready for this baby as soon as it's born, and you're going to have the prostaglandin E. So that way you can get the baby intubated with these meds, and it will actually improve their outcome. And once they've repaired the pulmonary artery and the aorta like flop, the surgery where they do the arterial switch, usually they have good outcomes. Okay, that's it for transposition of the great arteries.
Okay, moving along, we're going to go over to the Truncus Arteriosus. So this is where a single blood vessel arises from the right and left ventricle instead of the normal aorta and pulmonary artery. So typically you have the aorta that's going to be coming from the left ventricle and the pulmonary artery that comes from the right ventricle. The pulmonary artery then goes to the lungs where it oxygenates the blood, and then it returns through to the left ventricle where then it gets pumped to the, through the left atrium to the left ventricle where it's pumped through the aorta to the rest of the body. So this is where both vessels are just spanning from both ventricle. So in a sense, you're going to have mixed blood, and that's why it's another cyanotic defect of the heart. There's 3 types. The most common is where there's a short pulmonary artery from the base of the trunk and it divides into right and left pulmonary arteries. Then type 2, it's where the left and right pulmonary artery arise from the posterior side of the trunk. And then type 3 is where left and right pulmonary arteries arise from different origins of the lateral side of the trunk. The signs and symptoms of this would be bounding pulses, widened pulse pressure, signs and symptoms of congestive heart failure. You'll have a harsh murmur and cardiomegaly. It's important to treat this soon because what's going to end up happening is the baby's going to go into worsening of congestive heart failure, and that's no good. So you're going to manage that with diuretics, digoxin, and ACE inhibitors. Then what you want to do is then have them go to surgery. So the surgery for this is where they're going to separate the trunk. So I'm going to just do a quick drawing. And remember that you have on the left ventricle side, you have the aorta coming off. And then the right ventricle side, you have the pulmonary artery. So in the truncus, you're just going to have this big old trunk where they're both spanning from the same thing. So in a sense, there's a defect right here. So you're going to, in the surgery, they're going to patch the ventricular septal defect, and then they'll separate the 2 vessels using the Rastelli procedure or the Rastelli repair. The baby will be on bypass, and then what they do is they just, patch on a new artery and a new valve so that, they can have the 2 separate vessels. And then that's it. Next up for our cyanotic cardiac defects is tricuspid atresia. So this is where you have failure to develop the tricuspid valve, or it's a small to non-existent right ventricle. With this, you'll notice a PFO or a VSD present. They may also have pulmonary stenosis or atresia. The signs and symptoms of this is dyspnea, CHF, and a murmur. So to treat this, you're going to do the same thing as most of the other cardiac defects. You're going to have them on the prostaglandin in order to keep the PDA, and in order to keep the ductus arteriosus open. Okay, and then for the surgery, it's going to be similar to Tetrology of Fallot, where they do the Blalock-Taussig procedure, where they add a shunt in order to oxygenate the heart and lungs better. It's pretty simple, and with this, patients usually go home shortly after that procedure. Okay, last but not least of the cyanotic heart defects is a hypoplastic left heart syndrome. So this is where there's an obstruction of the blood to the left side of the heart. So usually the left side of the heart is underdeveloped. You'll have an absent or small mitral valve, left ventricle, and aortic valve, and they may even have an atrial septal defect. The signs and symptoms of this is tachypnea, dyspnea, CHF, lethargy. They're usually mottled, cyanotic. They have decreased pulses, pulmonary congestion, edema, and cardiomegaly. This one is a doozy. These patients don't necessarily have the best outcomes, but if they do the 3-step process, the surgical procedures to help repair this, they sometimes have good outcomes. If they don't, then unfortunately these kids need to be they require a heart transplant. But in order to try to repair this, they're going to first have, hold on, let me backtrack. They need to maintain that PDA open, okay? Again, this is a patent ductus arteriosus. It's a fetal shunt. I've mentioned it before. This helps, it's going to have mixed oxygenated blood, but this helps at least oxygenate some parts of the body during the time where they're repairing the heart. So you're going to have them on the prostaglandin E. Okay, and this is crucial. All right, and usually when these babies are born, you're going to have this on hold. Okay, this one, prostaglandin. All right, the first surgical procedure is called the Norwood procedure. They usually do this one within the first 2 weeks of life. This is where they're going to build an aorta at least a bigger one if there is one that's smaller. And they're also going to use that Blalock-Taussig shunt. This is to help in order, if the PDA does close, at least they have some sort of shunt to provide blood to the body. Even if it's not super oxygen rich, at least the body is getting some sort of oxygenation. Then after they do that procedure, they're going to do what's called the Glenn procedure. What they're going to do here is disconnect the superior vena cava from the heart and connect it directly to the pulmonary artery. And then from here, they're going to remove the Blalock-Taussig shunt. They don't need it anymore because now the blood is being sent straight to the pulmonary artery where it can get oxygenated. The last procedure of the three-part process is known as the Fontaine procedure. Oh, sorry. This one is around 2 weeks of life. This one is around 4 to 6 months of life. And this one is when they're about 3 years old. Okay, the Fontaine. All right, with this one, they're going to disconnect the inferior vena cava from the heart and connect it directly to the pulmonary artery. And then what they're going to do is through this they're going to use a conduit. All right, a conduit, something like similar to that. The conduit is going to have a small hole or a fenestration by, let's say this is the heart and that's the conduit. They're going to make a hole right here to the right atrium, so that the heart can get some blood and then it pumps through the rest of the body, and then the right ventricle becomes the main pumping ventricle. All right. So this whole thing, the hypoplastic left heart syndrome, is not very good. I mean, they do have positive outcomes, but more than likely they'll end up on the transplant list. All right, well, that's it for this video. I hope you guys like the idea of the Diagnosis Spotlight series. If you guys are interested in more videos like this, comment down below. Give me some feedback on it. Like this video, it helps my channel. Please subscribe if you haven't already, and I'll catch you guys in my next video. Bye!